I'd like to start out by thanking Dr. Yu for inviting me to Seoul National University and to this special symposium. I learned so much listening to the fellow presenters this morning, and I'm impressed by all the research being done by retinal degeneration researchers right here in Korea. So my research is on bone marrow, using bone marrow stem cells as treatment for retinal disease. And I got involved in this area of research when I joined UC Davis as a faculty some 13 years ago. And at that time, using stem cells as a treatment for eye disease, retinal disease, was sort of a pipe dream. It's like science fiction. And 12, 13 years later, many clinical trials are being done not only on stem cell therapy, but gene therapy. So we've made huge advances. And today what I'd like to do is go over the research that we've done along with research other people have done in support of using bone marrow stem cells as a treatment for retinal disease, and some of the non-orthodox work that have been done along the way as a byproduct of some of the research we've been doing. So, despite many advances in the field of ophthalmology, it's a little humbling to know that blindness remains a very common condition worldwide, and currently there are 37 million people who are blind, and an additional 127 million people who are visually impaired. And if you look at the leading causes of vision loss that we cannot effectively treat with surgery or medical therapy, they remain causes vision loss associated with retinal dysfunction. And this is because to this day we have no treatment to limit or reverse vision loss associated with retinal degenerative conditions or ischemic conditions. And so as a result, age-related macular degeneration remains a leading cause of visual impairment and legal blindness in the elderly population. And diseases like diabetic retinopathy remains a leading cause of blindness in the working age adult population. So how can we treat these patients? So one strategy is regenerative therapy. And the goal of regenerative medicine in treating retinal disease is to preserve vision by preserving the damaged retinal tissue, whether they be retinal neurons or retinal vasculature, and as a result, we hope to preserve retinal function. One of the strategies that people have used and described earlier today is to use stem cell therapy. And depending on the source of stem cells, the justification for using cell therapy is one of two folds. One is tissue replacement, and this is what most of us think of as the goal of stem cell therapy. And for this goal, the ideal choice would be pluripotent stem cells, in particular embryonic stem cells or induced pluripotent stem cells. And clinical trials, early phase, has already been studied using these pluripotent stem cells differentiated into RP cells and injected into the subretinal space. Now, a second approach is rescue therapy, as was described, and we hope to obtain this effect using the paracrine trophic effects that's been described with adult stem cells. So we all have stem cells in our bone marrow and other parts of our body, and if we can use our own stem cells to achieve retinal regeneration, autologous stem cell therapy is possible. And one of the nice things about rescue therapy versus tissue replacement is the cell therapy may not be disease specific, because the paracrine trophic effect of adult stem cell therapy appears to be dependent on the disease state of the target tissue. And I'll show evidence of our work in support of that. So why are we looking at stem cells in bone marrow in particular? Well, it's the richest source of adult stem cells, and it's the best characterized. And it's been known since the late 1990s that bone marrows contain stem cells that play an important part in normal repair and maintenance of our body. So if we injure a particular part of our body, there's a signal release into the systemic circulation, which reaches the bone marrow, and it mobilizes the stem cells to the target tissue, where the stem cells home into the injured tissue and promote tissue repair as part of normal repair and maintenance. So the paracrine-trophic effects of these stem cells are well characterized. However, there is some data also showing that these multipotent stem cells have potential for tissue engraftment long term and some plasticity to become the part of acquire the features of the damaged target tissue. So the mechanism of tissue replacement is also potentially possible, although most stem cell experts think that the potential might be a little limited using adult stem cells. So in bone marrow, there are different types of stem cells, and often when we read the literature, there is some confusion as to what cells are actually used. And I just want to clarify that there are actually 3 groups of stem cells that people have explored, extracted from bone marrow as potential regenerative treatment. And probably the most commonly done preclinical studies of bone marrow stem cells are actually mesenchymal stem cells. Less commonly done are hematopoietic stem cells that are used for bone marrow transplantation in humans. And in humans, CD34 and CD133 is often used as a cell surface marker to identify these hematopoietic stem cells. Now, a lot of clinical trials that claim to use bone marrow stem cells actually are using mononuclear cell fraction of bone marrow. And this is actually a crude cellular mixture that contains mostly blood cells and monocytes, and very few, less than 0.2% of these cells are CD34, and even fewer percent of the cell mixture contains mesenchymal stem cells. So this is a figure from one of the review articles that I recently published, just clarifying how these stem cells from bone marrow are isolated. So if you get a bone marrow aspirate and culture the bone marrow aspirate in a regular tissue culture plate like this, the cells that stick to the plastic and expand in culture are thought to be mesenchymal stem cells. And so just by passing bone marrow through culture a couple of times, you can actually harvest mesenchymal stem cells. And people have isolated mesenchymal stem cells as such and injected into the eye as tissue regeneration. Another method is to take the bone marrow aspirate and pass it through a phycogradient separation, which isolates serum and red blood cells from the mononuclear cell fraction. As I mentioned, this mononuclear cell fraction by itself has been injected into the vitreous for tissue regeneration. The approach we've taken is the idea that CD34 cells are the critical regenerative cells in the bone marrow, and to enrich and obtain the highest concentration of these cells, we hope to get the safest and most effective cell treatment. And the step involved here with magnetic cell sorters, we do a positive cell selection of CD34 positive cells, and this step is actually time-consuming, costly, and very important. It takes, in our clinical trial, several hours to do this step. And once you identify CD34 cell enriched fraction, you can also inject it into the eye for tissue regeneration. So let's talk about mesenchymal stem cells. We think of this as a new concept, but mesenchymal stem cells was first described in the 1960s. And if you look at the regular bone marrow aspirate, it makes up less than 0.1% of bone marrow cells, and in the mononuclear cell fraction, it makes up less than 0.1% of the mononuclear cell fraction. So it is not a major component of bone marrow. But they can easily be expanded in tissue culture, and it's well accepted that these cells can easily differentiate to cells of mesodermal origins, such as bone cells and adipose tissue. Now, the mechanism of action of the mesenchymal stem cells is thought to be predominantly secretion of trophic factors, and detailed study of the biologics that's secreted by the cells appear to be through extracellular vesicles, in particular exosomes that I'll talk about later. And various neurotrophic and angiogenic factors have been found to be secreted by these cells that may have therapeutic effects. Now, the mesenchymal stem cells, as I mentioned, are often harvested from bone marrow, but There are other tissues, such as adipose tissue and placental tissue, that contain mesenchymal stem cells, and scientists have used various tissue sources to harvest mesenchymal stem cells, and they can easily be expanded and obtained in tissue culture. The problem with this is that there's a lack of homogeneity in terms of the stem cells that are harvested using this method. And so the International Society of Cell Therapy established some cell surface marker criteria, and you have to have 95% purity of these cell surface markers for mesenchymal stem cells and lack of cell surface marker for hematopoietic stem cells to say you're actually working with mesenchymal stem cells. But even with the cell surface marker characterization, the cells harvested from one lab that tends to differ and behave differently from cells from other sources. So that's one of the issues with mesenchymal stem cell research. The nice thing about mesenchymal stem cells is that they can be expanded into culture, and the cell surface antigen is not mature, and so allogeneic cell therapy may potentially be possible, although there is some preclinical evidence showing that allogeneic mesenchymal stem cell therapy is not as totally effective as autologous mesenchymal stem cell therapy. Nonetheless, they have been used in non-ocular clinical trials as both autologous and allogeneic cell therapy, and there is phase 1 and phase 2 clinical trial evidence with follow-up of more than 10 years of using this cell therapy for intra-articular cell transplantation. They've also used the cell therapy for intravenous and intrathecal transplantation for patients with MS, and we have follow-up of more than 2 years. So if I look up clinicaltrials.gov and look at mesenchymal stem cell therapy, there are over 800 listings worldwide of autologous and allogeneic use of mesenchymal stem cell therapy, including treatment for graft versus host disease, hematologic disorders, diabetes, and various organ diseases, including eye disease. And there are 13 listed under mesenchymal stem cells for eye disease. So some of the published results beyond just listing on clinicaltrials.gov using mesenchymal stem cells is a phase 1 evidence of safety using allogeneic intravenous mesenchymal stem cells for pulmonary fibrosis conducted in the US with 9 patients. Phase 1-2 evidence for osteoarthritis in Spain with 15 patients using autologous mesenchymal stem cells enhanced with hyaluronic acid. Phase 2A evidence of severe ulcerative colitis study done in China of 36 patients showing safety and efficacy of allogeneic administration intravenously. And then lastly, a phase 2A study of non-ischemic cardiomyopathy, industry-sponsored in the US of 10 patients, where they administered allogeneic cell therapy that is ischemia tolerant. It's a special culture condition for mesenchymal stem cells, and they noted some increase in LV function, and another 2A study of stroke therapy. So of note, there is no phase 3 study in the US or nationwide using mesenchymal stem cell therapy for any indication. So what about using mesenchymal stem cells for retinal degeneration? Well, there's a lot of published data, preclinical data about using mesenchymal stem cells, and most of them agree that subretinal injection results in preservation or slowing down of retinal degeneration. Now, there are also published reports that intravitreal injection of mesenchymal stem cells can also preserve retinal degeneration, maybe perhaps less effectively. But many of these papers, if you look at the figures very carefully, you will note that there is abnormal proliferation of these cells in the vitreous cavity, often above the retina and behind the lens. The authors never mention these things, but as an ophthalmologist, I can't imagine this being very good for our patients. So one of the studies done by colleagues of mine at UC Davis was to explore using in vivo retinal imaging the effect of intravitreal injection of human mesenchymal stem cells from bone marrow in non-skin mice. And what they found is that within days of intravitreal injection, you could see marked media haze, and by OCT, these tractional membranes that developed from intravitreal proliferation of these cells, which resulted in severe deformity and damage to the retina. And so intravitreal injection, at least in this model, doesn't seem very safe. And this is not an immune reaction to human stem cells because we are using non-skin mice. So among the ocular clinical trials that have been listed on clinicaltrials.gov, the trials mention intravitreal, intravenous, subtenon, subretinal, even retrobulbar injection of mesenchymal stem cells. And they are all phase 1 or 2 studies proposing autologous or allogeneic cell therapy. And indications range from anterior segment disease, such as Sjogren's syndrome and graft-versus disease, and posterior segment disease, such as glaucoma, macular degeneration, and retinitis pigmentosa. And there's several listings of mesenchymal stem cell therapy for a study called SCOTS, where they will use mesenchymal stem cells to treat various retinopathy and optic neuropathy, including glaucoma. So something about SCOTS study. SCOTS stands for Stem Cell Ophthalmology Treatment Study. It is a study conducted in Florida by a private practice ophthalmologist, retina specialist. And he's actually published a few case reports in an open access journal regarding outcomes of a couple of his patients with serpiginous and optic neuropathy. And if you read his case reports, he says his study is NIH verified, except NIH has not supported his study and doesn't know anything about his publication mentioning NIH. And so if you look at the methods section about the mesenchymal stem cells he supposedly used for autologous bone marrow stem cell therapy, it's not clear that these are actually mesenchymal stem cells he's using because he never cultured these cells. He said he used an FDA-approved centrifuge device to harvest these cells. And so he's probably using the mononuclear cell fraction because there is a FDA-approved device to harvest mononuclear cell fractions. And finally, he does admit this is a patient-supported open-label study, which he advocates, and these are important factors to know about these stem cell clinical trials, even listed in clinicaltrials.gov. So, and by the way, he does not report any adverse side effects. So the only clinical trial that I could find published in the literature that seems to really use true mesenchymal stem cells was a study conducted in Iran and published very recently. It was a phase 1 study where autologous intravitreal injection of mesenchymal stem cell was proposed for patients with retinitis pigmentosa, and they actually treated 3 patients, and they said 2 of them tolerated the treatment well, but the 3rd patient started developing retrolental and epiretinal cellular proliferation within 2 weeks of injection that progressed to a white cataract and NVI by 3 months with severe loss of vision. And the interesting thing is this group took the same human stem cells and injected it into a mouse model of retinal degeneration and found the same changes. And they said if they took the stem cells from the other 2 patients that tolerated the treatment in clinical trial, they didn't see such an effect. So to me, it suggests that there's something different about these stem cells in the way they harvested, and some minor variations in the way you harvest can actually make the cell therapy or highly hazardous to the eye. So it's a little unpredictable in terms of safety of using intravitreal injection of mesenchymal stem cells. So in summary, as I mentioned, stem cells that we can explore for paracrine-trophic effects of these cells. There's preclinical and early clinical trial studies showing mesenchymal stem cells can have trophic regenerative effects, easy to harvest, but some safety concerns about intravitreal injection. Human CD34 cells appear to be well tolerated intravitreal with autologous cell therapy, and we're starting phase 2 study. And mononuclear cell fraction is a crude cellular fraction that's easy to obtain, It's well tolerated, but it's a cell mixture with very few number of stem cells, and efficacy results have been somewhat inferior to using CD34 cells. So future directions using bone marrow stem cells. Well, I hope to eventually get funding to explore these cells as a potential treatment for retinal regeneration as well as other retinal vasculopathies such as diabetic retinopathy. We are exploring approaches to enhance the effects of these stem cell therapy using exosomes, as we talked about, potential of using repeat dosing, and other looking at methods of cell alteration with gene therapy or other methods to make them more effective. So I'd like to thank thanking my many collaborators at UC Davis, including the members of the stem cell program, Dr. Betty at the Cancer Center who performed all the bone marrow aspiration, Dr. Chris Murphy at the vet school has shared his animal equipment with us, members of the Advanced Retinal Imaging who has performed in vivo retinal imaging, preclinical studies as well as our clinical trial, as well as the members of the Vitreoretinal Laboratory who has performed microarray analysis as well as immunohistochemical studies. And for the upcoming trust study, I thank MS for their ongoing collaboration and NEI for their support. Thank you.